Good morning, doctors and FMGE aspirants. This is Dr. 𝗧𝗵𝗶𝗀, a general surgery resident from Lady Hardinge Medical College. And today we join the sessions to know this must know and most important topics discussions, which is a brief discussion part. And if you see this discussion, it is one of the gold standard for your upcoming FMGE examination. And if you read this session or if you take this session much interestingly or with much enthusiasm, then you can crack your examination in your very first attempt. Fine. The first subject I'm going to take, it is the anatomy. We'll move on to the first part. First one, what they are started asking about this embryological arches and derivatives. And if you see about this embryological arches and derivatives, we know there are this first pharyngeal arch, second, third and fourth. Okay, first, second, fourth, third, fourth, and we know the fifth one will regress, and sixth one means there will be formation of few contents only, but mainly will rely only on first, second, third and fourth. If you see about this one, then we need to know about few things. One is what? One is this nerve supply. Second one, it is the arterial supply. So in recent FMGE examinations, they ask this question, like there is a child who is this newborn who is having these features of continuous murmur. Okay, continuous murmur. Okay, they didn't ask you this diagnosis. You know, if there is a child or an infant or the newborn and is presenting with features of a continuous murmur, what is the first differential diagnosis you will think of? First you will think of patent ductus arteriosus. You know this answer and they know that you know this answer, but they won't ask you these things. What they will ask you which of the following pharyngeal arch artery does give origin to this patent ductus arteriosus, or the ductus arteriosus is from the which of the following pharyngeal artery. So just remember this patent ductus arteriosus, it is what? It is due to the ductus arteriosus, and this ductus arteriosus, it is what? It is the sixth pharyngeal artery. And they will ask you not just sixth pharyngeal artery, they will ask you which of the following sixth, is it on the right or is it on the left? You can see it is the left sixth pharyngeal arch which give rise to this ductus arteriosus. So this is how they will ask you. Then next time they can ask you which of the following artery will be supplied for this first pharyngeal arch. It is what? It is the maxillary artery. And if they will ask you the second one, remember for this second one, everything will start or will be having these letters of S. So it is what? It is the stapedial artery. So the second one, it is what? It is the stapedial artery. And third one, if you see, as I told, it will be supplied by the glossopharyngeal nerve. Okay, it will be supplied by the glossopharyngeal nerve. And next, if you see this third alphabet, it is what? It is the C, A, B, C. So remember, the third will be supplied by the internal carotid artery. By the internal carotid artery. Yeah, you are getting it correct. You are in pace. Fine. And next one, the final one, if you see these two nerves, SLN and RLN, they are the branch of the vagus nerve. And remember, this fourth arch, it is what? It will be having this supply from these two arteries. It is what? The subclavian artery. And the next one, it is the arch of aorta. And we know, like they will ask you here, the point of confusion arises here. They will ask you which of the following arteries a derivative of right fourth pharyngeal arch artery. So if they ask you, you need to answer the right one. It is what? It is the subclavian artery. You can see here, it is the ventral aorta, and here you will be able to see this fourth arch arteries. On the right side, you will be able to see this is what? This is the right subclavian artery. This is the right subclavian artery. Whereas contrary to this, on the opposite side, it is what? It is the aortic arch. And we know this aortic arch, it is normally situated on the which side? Yeah, guys, it is situated on the left side, guys. And next, they will ask you about this, which I told you, right? The sixth arch arteries. The sixth arch arteries on the right side and on the left side. On the right side, I told you, it is what? It is the pulmonary artery. It is just this right pulmonary artery. And we know in left side, it will give rise to this pulmonary artery. But along with this pulmonary artery, it will give rise to this one more structure which is known as ductus arteriosus. Ductus arteriosus, right? Then about this pharyngeal arch derivatives. Pharyngeal arches, we know it will give rise to the glands. And if you see about this gland, which is what? Which is this inferior parathyroid gland and superior parathyroid gland. So just remember, if you see here, this image, these are the few derivatives you need to know from the arches. If you see about this first arch, it will give rise to this bone, which is this malleus incus, and this Meckel's cartilage, which will give rise to the mandible. Okay, so the first one, it will give rise to the alum. Okay, and it will be supplied by the CM, which is the mandibular branch of trigeminal nerve, which is this fifth nerve. Fine, that is the fifth nerve, V5-1. Next, if you see about this second arch, it will be having this all S structures, the steps, the styloid process, and the hyoid bone will be having this two structures. The two horns, one is this lesser horn and another one is the greater horn. So remember, as I told you, the second one will be having this S sound. So if you see the artery supply, it is what? It is the stapedial artery, and the derivative here, it also will be having this letter S. So one is what? One is the stapes, then the styloid process, then this lesser. So two S are there. So the second arch will give rise to this lesser horn of the hyoid bone, lesser horn of the hyoid bone. Okay, and about this third arch, it will give rise to this greater horn of the hyoid bone. So third arch will give rise to this greater horn of the thyroid bone and hyoid bone, sorry, and the fourth arch, it will give rise to this cricoid cartilages and the thyroid cartilages, cricoid and the thyroid cartilages. Okay, fine. And these are these arch derivatives that you should know for must for these pharyngeal arches. And as I told you, these are the two parathyroid glands. They will get origin from this third and the fourth pharyngeal arches. But what is the catch here? If you see about this third, see, it is the third one which is giving rise to this inferior parathyroid. It is not the superior one. So if you see in usual settings, the first one above this thyroid gland, we know there is this parathyroid glands, there is the superior parathyroid gland and the inferior parathyroid gland. There are the superior parathyroid gland and the inferior parathyroid gland. So if you see by nomenclature or by sequence, what should be there? This superior one will be origin from which of the following? Like if you see here, the superior one usually it should be from the third one, right? But here the catch is what? If you see this catch, this third arch will give rise to this inferior parathyroid. It will give rise to which one? It will give rise to this inferior parathyroid glands. Whereas the superior one, it will give rise to the, it will be given by the fourth pharyngeal arch. So fourth one will be given by the superior parathyroid. Right? So that is the catch here. So third one, the inferior parathyroid glands, it will be from the third arch, whereas the superior parathyroid glands, it will be from the fourth arch. And as I told you, the mnemonic, all the S things, fine, all the S things. Yes, Dr. Navas, all the S things. If you see about this, all the S things like stapedial artery, lesser horn of the hyoid bone, then the stapes, okay, then another one S, which is what? Which is this styloid process. All of this, it will be derived from the second arch. But just remember this another S1, which is what? Which is this 𝗵𝗵𝗶𝗀 ligament. This 𝗵𝗵𝗶𝗀 ligament, it is not derived from this second pharyngeal arch. It will be derived from the first pharyngeal arch. First pharyngeal arch. So, as a point of conclusion, you need to know about these arches: the first arch, second arch, third arch, and fourth arch. And about the dose supply, remember 5, 7, 9, 10. Okay, it is the 5, 7, 9, and 10. Okay, it is the 5, 7, and 9, 10. Okay, and about these arteries, you need to know first one, it is what? It is the maxillary artery, and the second one, it is the S artery, which is what? Which is this stapedial artery, and third one, it is the third alphabet, it is what? It is the internal carotid artery, and fourth one, it is what? It is the subclavian artery and arch of aorta. On right side, it is the subclavian artery, on left side, it is what? It is the arch of aorta. And for the sixth arch arteries, it includes two arteries. As I told you, it is what? It is this pulmonary artery on this right and left side, and on left side especially, we have this ductus arteriosus. Right? On left side, it is what? It is the ductus arteriosus. So these are the pharyngeal artery derivatives you should remember. Next, we'll move on to the muscular part. So, if you are able to remember about these muscles, it's well and good. If not, just remember by their nerve supply. Nerve supply. Like, so how will you remember? Like, if you know this muscles of mastication. Like, remember, it is the muscles of mastication. Yeah, good, Dr. Kanvaskar. If you see about these muscles of mastication, we know this will be supplied by the trigeminal nerve. Trigeminal nerve, which one? The mandibular branch of this trigeminal nerve. So, see, all of the muscles of the mastications will be supplied by this trigeminal nerve, and it will be derived from the first pharyngeal. Okay, it will be derived from this first pharyngeal arch derivatives. And second, if you see about the second one, this it will be supplied by the facial nerve. So, the muscles of this facial expressions, it will be supplied by the facial nerve. And here you need to see and you need to focus on these two muscles, which is what? Which is this anterior belly of digastric and the posterior belly of digastric muscle. if you see about this anterior belly of this digastric muscle, okay, it will be supplied by the mandibular branch of this trigeminal nerve, and it will be from the first arch. Whereas this posterior belly, it will be supplied by the what? It will be supplied by the facial nerve, and it will be from the second arch, right? And thus third arch, it will be giving rise to this muscle, which is what? Which is this stylopharyngeus muscle. Which is what? Which is this stylopharyngeus muscle. And as I told you, this fourth arch, it will lead to the formation of this pharyngeal muscle. Pharyngeal muscles. That's why our pharyngeal reflex, it will lies on the 10th cranial nerve. Okay, guys, I hope we are going well and good. If any, if you feel this, like what I am telling is it's in a bit faster pace, please let me know so that I can reduce the pace. Right? Final point to note, you just remember this ductus arteriosus, it is from this left 6th pharyngeal arch derivative. Okay? And next, we'll see about the neural tube defect. And it is one of the most important topic, and it is being repeated in all of the examinations. We see about the neural tube. They told you it is what? It is the tube. So, if you see any tube, for example, take this pencil. Okay? Imagine it is a tube. It will be having these two ends. One is this anterior end and the posterior end. Okay? One is this anterior end and another one is the posterior end. At some point of time, this neural tube should close. This anterior part also should close, and this posterior part of the should close. So, if it doesn't close, then it will remain as hollow. Okay? It will remain as a hollow space. So, remember. So, usually this anterior neuropore, it will closes by the day of 25th day, fine, and the posterior neuropore, it will closes at the day of 28th. So, remember, anteriorly, it will close first at the 25th day, whereas this posteriorly, it will close by 28th day. And there is some conditions in which this anterior neuropore will fail to close, and there will be few more conditions in which this posterior neuropore, it will be failed to close. And what are the conditions which is happening because of this anterior neuropore failure of fusion? If you see this anterior neuropore failure of fusion, it will lead to this condition which is known as anencephaly. If you see, this is what? This is the anencephaly. They asked in this FMGE question like, which of the following neural tube defect which happens due to the failure of closure of this anterior neuropore at 25th day? What will be your answer? It is what? It is the anencephaly. And next, if you see this anencephaly, I told it is the failure of closure of this anterior neuropore, and we know this anterior neuropore, it will also consisting of the skull. So, in this the brain will be exposed to the outside. And if you see the one more resemblant condition which looks almost similar to this anencephaly, but it will be happening at the midline. It will be happening. If there is any failure of closure at the midline level, it will be of two conditions. One is what? One is known as cranioschisis and another one is brachial. Okay? If you see this cranio, means in cranial cavity, if there is no midline closure, so we'll call them as cranioschisis. Whereas, if there is any failure of closure at this midline level in spine, we'll call them as brachial. Okay, fine. Just remember. And next about this posterior tube. Like posterior pore, it also should close at some day, right? This posterior pore will usually close by the 28th day. And we know this posterior neuropore, if there is any failure of closure, it leads to this condition which is known as spina bifida. Okay, this condition which is known as spina bifida. And this spina bifida, it can be of different types. Either this spina bifida, it will be consisting either of just the meninges, or it will be having this meninges along with this nerves, or the spinal cord derivatives, or just having a tuft of hair. So, these are the three specifications or three subdivisions this spina bifida must have. Okay. So, if you see, if there is any failure of closure of posterior neuropore at 28th day, it will result into this spina bifida. So, the spina bifida can be spina bifida occulta or spina bifida which causing these two conditions which is known as meningocele and myelomeningocele. If you see, if there is just only meninges, so it is what? It is the meningocele. This is the meningocele. Whereas if you see, there is this presence of meninges along with this some spinal cord derivatives or nerves are present, so it is known as myelomeningo. Right? And next, I told you there is no any outside defect. There is no any outside defect, but if you are able to see this type of tuft of hair in the sacral regions or around the sacral regions in the posterior aspect, so it is what? It is the spina bifida occulta. Okay, and this is how this meningocele and myelomeningocele occurs. Like if there is any nerves present, it is known as myelomeningocele, and if there is no nerves, it is known as what? Meningocele. Just remember. Next, about one more condition, which is more interesting one. These are like if there is any anterior neuropore defect and if there is any posterior neuropore defect, what will happen? But in some conditions, you see this anterior neuropore closes well and posterior neuropore also closes well, whereas there is this absence of neck. So remember, if there is absence of neck, remember this INN for absence of neck. So if there is absence of neck, it is known as anencephaly. So in a case of anencephaly, there will be no neck present. Right? There are few more conditions which occurs in a case of brain. If there is no rugosities, see this is how this normal brain which is having this rugosities, like this sulcus and gyrus. So if there is no sulcus and gyrus, it is known as lyssencephaly. It is known as lyssencephaly. Okay, and we know this brain, it is consisting of two halves, the right half and the left half. And remember, if there is no half separation, if the brain instead of separating into right and left half, if it remains as a single part, we'll call them as holoprosencephaly. We'll call them as holoprosencephaly. Just remember, fine. And see and tell me, it is related to this one condition. Can you tell me what is this condition in which this lip is not fused in the midline? It is what? It is the cleft lip. It is the cleft lip. Yeah. And if you are able to see this kind of holoprosencephaly, cleft lip, and all this midline defect, because if you see, there is no separation, there is no midline in the brain. That's why there is no right and left. There is just one brain. And here there is this midline fusion defect, which leading to this cleft lip. And both of these things, along with the features of rocker bottom foot, will be classical for a chromosomal anomaly. Can anyone tell me which of the following chromosomal anomaly will have this? And as you read very well, it is what? It is the Patau syndrome. It is the Patau syndrome. It is the Patau syndrome which will have this association. So remember, Edwards syndrome, no, Edwards syndrome, it is the trisomy 18 and it won't have this central defects. It will be having this elongated fingers along with the features of elongated kidney, which is what? Which is this Harsho kidney. We'll see them in the pathology aspect. Okay, good. I like that you have this thing, like at least you have this motto of being answering. That's really well. Just keep this Josh alive for a few more days. Up to ho hi jayega. Okay, then we'll move on to the next part about this epithelium. Okay, about this epithelium, they are started asking in all the examinations, in the NEET PG as well, in the INSET as well, and in the FMGE examination as well. What they give is, they will give you this some slide. They will give this slides, and they will ask you which of the following epithelium is this, or which are the following organ is. Okay, sometimes they can give you this slides of this pancreas, about this beta cells of the pancreas, and they will ask you which of the following organ is this. It is what? It is the pancreas. Whereas sometimes what they will give is, they will give this sphere. You know, this is simple. Simple means it is a single layer flat cells. It is what? It is the simple squamous epithelium. And we know this simple squamous epithelium, it is present in what? In the alveoli. Next one, if you see, next one, it is what? It is the transitional epithelium. Transitional means it is what? It is the changing epithelium. Once under stress or under increase in volume, this transitional epithelium, it will change its shape. So this type of transitional epithelium, it will be seen in a case of bladder. In bladder, you will see this transitional epithelium. And next, you will see this cuboidal epithelium. Means this cuboidal epithelium, which help in this filtration process, will be seen in a case of, there will be these cubes. You can be able to see some of these cubes. This image is bit unclear. So if you are able to see this type of cube-shaped cells and the central nuclei, it is what? It is this cuboidal epithelium. One of the example of this cuboidal epithelium, it is what? It is the kidney. Next, about where there is this absorption along with this secretion takes place. So it will lead to this type of epithelium where this epithelium presents. And here you will be able to see this nuclei at the base. So it is what? It is the columnar epithelium. And this columnar epithelium will be present in the stomach and in our intestine. And next, you will be able to see this type of epithelium. As I told you, there is this different shapes, and based on the stretch, they will stretch out, they will become elongated. So it is what? It is the transitional epithelium. And we know when a bladder starts filling, initially the bladder volume will be like this, and when it starts filling, this need to be stretched, right? And when it starts stretching, this epithelium also stretches. So it is what? It is the transitional epithelium, which will be seen in a case of bladder. Yeah. That's why we see one of the common cancers in bladder. It is what? It is the transitional cancer in the blood, right? And next, about the stratified squamous epithelium. As I told you, the simple squamous means it is one layer of cells. Whereas in the case of stratified squamous epithelium, the stratified means there is a multiple layer. It will be having this multiple layers. And we know if there is any multiple layer of the cells, it is known as stratified epithelium. And if there is multiple layer of this type of flat cells, so it is known as stratified squamous epithelium. And we know this stratified squamous epithelium, it will lines this esophagus. And in esophagus itself, there is a question which is known as metaplegia. Normal lining of this esophagus, it is what? It is the stratified squamous epithelium. As I told you, in stomach, there will be this acid secretions in stomach. So there will be having this columnar epithelium. Columnar epithelium. Okay. Any external opening to withstand stress and things will be having this squamous epithelium, like around this oral cavity and the vaginal orifice. All of this will be having this squamous cells, and in skin will be having this keratinized form of this squamous epithelium, right? So it is what it is, this columnar epithelium which is being changed from the squamous epithelium. So it is what it is known as metaplegia. It is known as metaplegia, and we know this metaplegia which is known as Barrett's esophagus. And remember one thing, it is not just this columnar epithelium, it is also presence of which cell? It is also presence of which cell? It is also presence of this goblet cells, which is this mucus secreting cell. So this columnar epithelium along with this presence of this goblet cell will call them as intestinal metaplegia. Okay, we'll call them as intestinal cells and intestinal metaplegia. And so that is what that is this Barrett's esophagus. And we know what is the name of the stain which we'll use for this Barrett's esophagus to see this goblet cells. Guys, any idea? That is what it is, the Alcian blue. It is the Alcian blue stain which we'll use for staining this goblet cells, which will be containing this acidic mucin. Fine. Next, about this tumor epithelium, this stratified or multi-layered cuboidal will be seen in a case of sweat glands, whereas this stratified columnar, this multi-layered columnar will be seen in a case of salivary glands. Next, about this one which is having this cilia. So we know this respiratory tract, it will be having this cilia. So in respiratory tract there will be presence of this epithelium along with this cilia. So it is what it is, the pseudo-stratified ciliated columnar epithelium. Okay, so actually it is a single layer, but it will show, it will be appearing as a multiple layer. And we know one more thing, that in a case of metaplegia in the respiratory tract, will it be a squamous metaplegia or a columnar metaplegia? What is the name of the metaplegia? We will see in a case of trachea. It is what it is, the squamous metaplegia, which we will see in a case of. So normally the respiratory tract will be having this pseudo-stratified ciliated columnar epithelium. Next, about the joints. ठीक है, अब joints पे चलते हैं. ठीक है, about this joints आपको कुछ चीजों याद रखना. Means you should know few things for must while solving the joint. First one, they will mostly test about this primary and secondary cartilaginous joints. Okay, if you know anything, if you don't know anything, just remember this one thing, this about this cartilaginous joints, this primary and secondary cartilaginous joints. Remember about this secondary. About the secondary, remember secondary for center. So whatever joints in the center, it will be having this secondary cartilaginous joints. Secondary will be this center. Secondary cartilaginous joints, it will be in the center. So what are the joints which present in the center? For example, our pubic symphysis, and then our this xiphisternal joints, all the sternal joints, like especially on the center, like the xiphisternal joints, and our vertebral discs, this intervertebral discs, all of this they will lie in this central point. So they are what? They are this secondary cartilaginous joint, right? And about this around or adjacent to the centers, you will be able to see this is what? This is the costosternal joints. All of this sternocostal joints, it will be what? It will be primary in nature. And sometimes they will ask you what is the difference between this primary and this secondary cartilaginous joints. If you see about this primary one, you will be able to see there is the only presence of this hyaline cartilage, hyaline. Okay, whereas the secondary, there will be a hyaline, but there is a person, ठीक है, बीच में there is a person in between this hyaline, okay, in the center or in between these two hyaline cartilage there is one cartilage which is what is this fibrocartilage present. That's why it is known as secondary cartilage. So remember, secondary cartilage, it will be having these two cartilages which will be this hyaline cartilage and this fibrous cartilage. And there is one more fixed fibrous joint which include this 𝗵𝗶𝗀𝗃 joints and this sutures. So they will ask you, 𝗵𝗶𝗃 is which type of joint? Whether this is a fibrous joint or a synovial joint. What will be your answer? Yeah, it is what it is, the fibrous joints. Next, and next about the synovial joints. The synovial joints, mainly it is what it is, the movements. So in synovial joints, you will be having an ample of movements. So you will be able to do maximum movements in which joint? It is synovial joint. And in synovial joint, there is a presence of this fluid which is known as synovial fluid. And this synovial joints which will be having this synovial fluid will be of different types. For example, if you see this, our shoulder joint, which will be able to perform this multi-axial movement. It is what is this ball and socket joint. Okay, one is this shoulder joint and another is the hip joint. Can anyone tell me what is the one more ball and socket joint? See, in here there will be two joints. They will make the point of confusion in here only. So see, there are two joints in here. Remember as 𝗵 and 𝗵. Okay, remember 𝗵 and 𝗵. So if you see this first joint, which is what, which is this between this malleus and incus, it is what? It is saddle joint. It is the saddle joint. Whereas if you see next joint, which is what, which is this 𝗵𝗵𝗀𝗀𝗃. Okay, 𝗵𝗵𝗃𝗃, it is what, it is the ball and socket joint. It is the ball and socket joint. Ask you this point of confusion. When there is two point of confusion, they will ask you a question. So this malleus and incus joints, it will be this type of joint which is known as saddle joints. Whereas this ball and socket joints, which is what, which is this 𝗵𝗵𝗃𝗃 joint. Okay, remember. Next, if you see, they will mark this first metacarpophalangeal joint and they will ask you which type of joint is this. Then you need to tell it is what, it is the saddle joint. If you see, it is the between this carpal and metacarpal. And next about this pivot joint, so you need to know about the first. Okay, see, first for everything you will try to say yes, but later on you realize the thing, no, it is not for me. So then you will tell no. So remember the first joint, it is what, it is this atlanto-occipital joint. It is what it is used to help to tell this yes. Whereas the second joint, which is this no joint, which is what, which is this between this atlas and axis, it is a type of pivot joint. So remember, it is the no joint. So initially you will tell, means because you are a bit immature, so you will tell yes to everything in them. But later on you realize no, ये मेरी बस की चीज नहीं है, तो इसीलिए then what you will do, you will say no, it is not for me. So you will tell no and you will avoid this unfortunate circumstances. Okay, फिर उसके बाद आगे बढ़ते हैं. As I told about this ball and socket joints. Next about this hinge joint, like example of this hinge joint where there is usually this uniaxial flexion and extension takes place. For example, your elbow joint, your knee joint. So it is a type of hinge joint, right? And about this ellipsoidal joint, these are the joints between this radius and this carpal bones, especially this wrist joints. And about this temporomandibular joints, these are the type of ellipsoidal joints. These are the type of ellipsoidal joints. Next, they will ask you, means like this, they will mark and ask you which of the following joint is this. As I told you, it is what it is at the level of knee, so it is what it is, the hinge joint. So you know it, guys, you better. Fine. With this understanding, we'll move on to the next part. Okay, आगे बढ़ते हैं. अगर आगे बढ़ेंगे तो this recently they will ask you these questions, like they will point some point in your examination. They will point some point, like for example, they will keep this finger or this point around this jugular notch and they will ask you at which vertebral level this point lies. Okay, remember this jugular notch, it will lie at the level of T2 to T3. This jugular notch, it will lie at the level of T2 to T3. Like for example, there will be this sternum and there will be this jugular notch. They will keep or point this arrow and they will ask you which of the following vertebral level does this exist. So it is at the level of T2 to T3. And next about this 𝗪sternum, and they will mark around this 𝗪sternum. Around this 𝗪sternum they will mark and they will ask you at which vertebral level it is. It is at the level of T9 to T10. And here the point of confusion next. See, about this umbilicus, you know this dermatomal supply, it is what, it is the T10. So it is not same. So remember, it is not dermatomal supply they are asking. They are asking you what? They are asking you the topographical level or which vertebra lies behind it. So remember about around the umbilicus, it is what, it is the L3 and L4. You want to choose, or if you are opted between choose one, choose L3. Okay, choose L3 because mostly they will lie around or over this L3 in most commonly. A good Dr. 𝗚𝗍𝗶𝘀, good Dr. 𝗵𝗵𝗿𝗺, good Dr. 𝗧𝗵𝗶𝗀, a good Dr. Anirudh. Fine. If they put some line, mostly in recent examination, they asked a line which is passing above this umbilicus. So in such conditions, you try to answer it as L3, but if not, mostly they will give this ranges or give this intervertebral disc level between this L3 and L. Okay. Next about this axis, it is what it is, this anterior superior iliac spine. So remember about this anterior superior iliac spine. How will you remember this? The name itself tells. So remember S1. So it is the S1 level. And on the posterior aspect, they will ask you, like, there is a patient who is presenting with features of pleural effusion. Now you plan to do a pleural tapping. Okay. Now you plan to do a pleural tapping to make the patient to sit, and you are percussing and you got the dullness. Now you want to do this pleurocentesis. Now you need to locate the scapula. They will ask you at which level this scapular inferior border located. So the inferior border of the scapula, it is located at the level of T7. It is located at the level of which level? It is located at the level of T7. Okay, it is located at the level of T7. Just remember this. And about this next point, now you are in your OBG posting, or it will be your anesthesia question. You got a patient who will be posted for this cesarean section. Now you plan to do a spinal anesthesia, and for spinal anesthesia, you are putting your two hands on the patient's back. Okay, and you are palpating the highest point of the iliac crest. You are palpating the highest point of the iliac crest, and you are seeing your thumb, means you kept one hand here, and you see this, your fingers will be meeting at the level. So they will ask you at which level the highest point of iliac crest lies in, or at which level you will give this spinal anesthesia. The one answer, it is what it is the L4, what it is the 𝗵𝗵𝗺 line. So this line, it is known as 𝗵𝗵𝗺 line. Okay. As I told you, as is, it is at the level of S1. So remember, don't confuse for this posterior superior iliac spine also. It is what it is the. Okay, so just remember the anterior and forget about the posterior. If you know this anterior, you will make sure you will make this thing correct. So anterior superior iliac spine, it is SI, looking like a S1. So it is the S1. Okay, it is what like mostly will do at the level of L3 to L4. So to locate this, we'll use this vertebra. So you will see this L4 vertebra, and we'll just go ahead and we'll able to palpate this intervertebral disc, okay, which is a secondary cartilaginous joint, and there we'll put up the needle. Fine. And sometimes they will give you this point. Okay, they will give this point, and they will ask you about this lines. If you see, if there is a line which is being transversed around this pylorus of the stomach, if there is a line which is transferring this pylorus of the stomach, it is at the level of which level? It is at the level of L1. It is at the level of L1. So it is what? That is the transpyloric plane, which is at the level of L1. Which is at the level of L1. Next, if you see the next one, below this costal. So this subcostal line, it is at the level of L3. As I told you, this is our umbilicus, and around the umbilicus, we will be having this L3. And if you are asking at the level of disc, it is this between this L3 and L4. So this L3, which is this subcostal plane, which is at the level of L3. And there is one more thing which is known as supracristal plane. It is at the level of L4. Supracristal plane, it is the level of L4. And final one, it is the intertubercular plane. And this between this tubercle, it is at the level of L5. Okay. This tubercular plane, it is lies at the level of L5. So remember, this transpyloric plane, it is at the level of L1. Okay. And next, about this subcostal plane, it is at the level of L3, and supracristal plane, it is the level of L4. Okay, fine. And intertubercular plane, it is the level of L5. Okay. Don't forget this umbilicus one. The dermatomal supply, it is T10. It is not the vertebral level. So the vertebral level, it is what it is between this L3 and L4. Okay. It is between this L3 and L4. Next, the most important part. Okay. Why it is most important? Because there is this 3 subjects integration. It will be asked in your surgery part, your ortho part, or from this anatomy part. You cannot tell this is anatomy questions. I didn't read it. Okay, it is the integrated questions. So अगर पूछेगा तो मैं जवाब देना पड़ेगा. Because this is the exam where you cannot tell any reason in your life. Because everyone will be having some part of problem. सबको कोई ना कोई दिक्कत तो रहता है. लेकिन जो भी होता है, जो भी आगे बढ़ता है, वो दिक्कत के साथ, he will be progressing ahead in his life along with these problems. अगर प्रॉब्लम नहीं होता, वो चिल रहता है, बंदा बिंदास रहता है. to make sure you are having the problems. Yeah, I know that you are having the problem, but make sure you are coming out of this examination with the problem and you are solving the problem after it. Okay, don't try to solve the problem now. The problem will get solved once you pass the examination. Okay, that is my kind of motivation. So just push yourself for next few more days and you will be coming out with flying colors. Fine. उसके बाद आगे बढ़ते हैं. Then if you see this first one, okay, it is what? This type of scapula, which is known as winging of scapula. And we know this winging of scapula, it is due to the injury of nerve of bulb. So it is what? It is the injury to this nerve of bulb, which is also known as injury to long thoracic nerve. And we know this nerve, which is most oftenly injured during this mastectomy procedures or any lymph node biopsy, are also known as sentinel lymph node biopsy procedures. Okay, so during these procedures, this long thoracic nerve or this nerve to bulb will get injured and it will lead to this condition, which is known as winging of scapula. And we know this long thoracic nerve, it will be supplying this muscle. What is the name of the muscle? Can you guess? It is known as Box's muscle. And if you see this long thoracic nerve, it will be supplying this muscle, which is what? Which is this serratus anterior. And if there is any damage to this muscle, which is the serratus anterior, which will lead to this phenomena. When you tell the patient to push your hand, you will be able to see this type of scapula, which is known as winging of scapula. Okay, फिर उसके बाद आगे बढ़ते हैं. Next, if you see this 𝗶𝗶𝗀, which is known as 𝗵𝗵𝗿𝗺, which is known as what? Which is known as 𝗵𝗵𝗿𝗺. And we know 𝗵𝗵𝗿𝗺, it is damage to the upper, remember, and it is the level of C5 to C6. Okay, we know the muscle which is causing this abduction of the shoulder till 90 degree. What is the name of the muscle which causes abduction of this shoulder from 15 to 90 degrees? So it is what? It is the deltoid muscle. So if there is any damage to this deltoid muscle, then there will be no abduction. So the arm will remain adducted. Then we know the flexors of this component, it is what? It is the biceps. So if there is any damage to the biceps, then we cannot flex it. Then the hand will remain in the extensor position. And we know one more thing, the biceps, it is what? Is it a pronator or a supinator? It is what? It is a supinator. So if the biceps is gone or the nerve supply to the biceps is gone, which is the musculocutaneous nerve, which is a branch from this C5-C6 trunk, then the patient cannot supinate the arm. So the arm will remain pronated. So remember, the arm is adducted and the arm is extended and the arm is what? Arm is pronated. Okay, and the arm is pronated because it is not supinated because there is no biceps muscle acting. So the arm will be adducted, then the biceps will be gone, so it will be extended and it will be in pronated position. And remember, and it also will be in internal rotation. It will be internal rotation. There will be this internal rotation, extension, and along with this pronation, and finally flexion at the flexion. Okay, finally flexion at this elbow level. So all of this thing, it is what? It is known as 𝗵𝗵𝗿𝗺. Okay, it is known as 𝗵𝗵𝗿𝗺, and during labor or delivery, when you apply the forceps, then at this moments, if you damage this brachial plexus, it will lead to this type of 𝗶𝗵𝗿𝗺, which is known as 𝗵𝗵𝗿𝗺. It is known as what? It is known as policeman hip deformity. Okay, deformity, and it is also known as 𝗵𝗐 tip or 𝗵𝗐 hand. Okay, it is also known as 𝗵𝗐 tip or this 𝗵𝗐 hand. फिर उसके बाद आगे बढ़ते हैं. One of the most important picture from the anatomy and the orthopedics. If you see this first point, there will be few arteries and the nerves which will be in relation to the humerus. First artery which we need to see, it is what? It is this posterior circumflex humeral artery. So we know this is a humerus bone. So if you don't know, just remember it is the humerus bone. Okay, and in humerus bone there is multiple relations. Okay, it is like a best friend of us because it gives pass to the multiple nerves and the multiple vessels, and most often they get injured. And once they get injured, what they will do? They will ask questions in your examination. So these two things will do. Once they get injured during a fracture, they will ask you this question, like in this fracture, which of the following nerve or this artery will be involved? Yeah, good guys. First, if you see around this surgical neck, there will be one artery which is what? Which is this posterior circumflex humeral artery, which is encircling this surgical neck, and there will be one more nerve, which is what? Which is this axillary nerve. And two of the structures will be damaged during the fracture of the surgical neck. There will be damage to this axillary artery and this posterior circumflex humeral artery. Next, Around this shaft of humerus, we know there is a groove which is known as a radial groove, which passes to this radial artery and this deep part of this bronchus artery. Deep part of this are profunda brachii artery. So this structure will be damaged when there is a mid-shaft fracture. So if there is a mid-shaft fracture, it will lead to this damage to this radial nerve and damage to this profunda brachii artery. Right? And next, about these two important nerves, one is the median nerve and the ulnar nerve. Remember, this ulnar nerve, it will supply this medial aspect of your hand. So remember, it is around the medial epicondyle. So remember, when you sometimes when you touch or when you put a knock over this medial epicondyle, you will see some tingling sensations, right? It is because of the involvement of this ulnar nerve. In examination, they will mark you this structure. Which of the following now will be in close relation to this structure? So it is what? It is the ulnar nerve. It is the ulnar nerve. Next one, there is this above this epicondyle, if there is any fracture occurs, we'll call them as supracondylar fracture. This is known as supracondylar fracture. And in supracondylar fracture, there is two structures will get involved. One is this structure which is known as median nerve. Okay, median nerve. If they given you this option as anterior introitious nerve, then you should choose anterior introitious nerve more than this median nerve. Okay. Then about the artery, which is what? Which is this brachial artery. And all of these things. So remember, this surgical neck of humerus, it is this axillary nerve along with this posterior circumflex humeral artery, and in the shaft, it is what? It is this radial nerve, and there is this profunda brachii artery, and around this supracondylar, you will able to see there is a median nerve on this brachial artery, and around this medial epicondyle you will able to see there is a nerve which is what? Which is this ulnar nerve. Okay, so if there is any damage or if there is any fracture, all of these nerves or this vascular structures will be impaired. Fine. With this understanding, we'll move on to this individual nerves. First one, as I told you, axillary nerve. You know, this axillary nerve will supply two muscles. What are the two muscles which will be supplied by this axillary nerve? One is this deltoid, and another one is what? It is the second muscle. It is what? It is the teres minor. It is the teres minor. It is not the teres major, it is the teres minor. And there is one more point of confusion. There is two muscles will be supplied by this spinal accessory nerve. The spinal accessory nerve, or this 11th cranial nerve, will supply two muscles. What are the two muscles? One is this sternocleidomastoid and the trapezius. Okay, you won't forget this question. Like spinal accessory nerve will supply two muscles, which is this sternocleidomastoid and the trapezius one. Whereas this axillary nerve will supply two muscles, which is this deltoid muscles and the teres minor. And this axillary nerve will supply around this region of this deltoid region. So if there is any deltoid muscle palsy, then this shoulder counter will be lost at this region. So there is this loss of shoulder counter, and there will be this anesthesia. So this anesthesia, which is known as regimental access, or also known as regimental anesthesia. Fine. And next about this ulnar nerve. Okay, is ulnar nerve is known as musician's nerve, or also known as Leber's nerve. Is ulnar nerve is a musician nerve or a Leber's nerve. Okay, it is, first let me tell you, it is the claw hand. Okay, and before that, what I asked you, yeah. So remember, ulnar nerve, it will supply this fine movements. Okay, it will be responsible for this fine movements. So it will supply this intrinsic muscles of the hands. So since it supplies this intrinsic muscles of the hands, which will responsible for your fine movement. So this is what this is known as musician's nerve. Musician's nerve, like you know, right? Musician's cotton. Like so, this is what this is. This musician's nerve. Fine. And this musician's nerve, it also will be responsible for this fluxions, the fluxions at the level of fingers. Okay, and it will helpful for this adduction of the hand and this abduction of the hand. So if there is any damage to this ulnar nerve, then there will be damage to this all of the following stuff. Fine. So if there is any damage to this ulnar nerve along with this sympathetic trunk. So ulnar nerve along with this sympathetic trunk, or this claw hand along with this sympathetic trunk involved, we call them as 𝗵𝗶𝗀𝗀 palsy. We call them as 𝗵𝗵𝗀𝗀𝗀 palsy. And next, it is just this claw hand. If there is just ulnar nerve involved, okay, it will lead to this type of claw hand, which is partial claw hand. So it is the claw hand. So as I told you, this ulnar, remember this ulnar, there is a L. Okay, there is a L. Okay, there is a L in ulna, so it will make L. Okay, so remember, it will cause flexion. It will cause flexion at the level of this joint, which is this metacarpophalangeal joint, and here it will cause extension. Whereas if there is no ulnar nerve, then it will lead to this type of hand, which is known as claw hand. So this type of joints, which is known as claw hand. So ulna L, so it will make this L. So it is this function of this ulnar nerve. Then if there is no function of this ulnar nerve, if there is any damage, it will lead to the formation of this hand, which is known as claw hand. Right? And to test this ulnar nerve, then to test this viability of this nerve, we'll use some test. As I told you, it will supply this hand muscle, so it will cause adduction. So introsea, which will causing this adduction. So to test this, we'll use this card, which is known as card test, which we use for adductors. Okay, adductors. So remember, that is the pad and dab. So palmar interrogae will help in this adduction. So we'll test with the test which is known as card test. फिर उसके बाद आके next test. Then this dorsal interrogae क्या करता है? It will help in this abduction. It will help in this abduction of these fingers. It will help in the abduction of the fingers. So if we want to test this abduction, we'll give a special name to this, which is known as 𝗃𝗏 test. Okay, we'll given this special name which is known as 𝗃𝗏 test. फिर उसके बाद आगे चलते हैं this test. We see this test, like हमने तो पूरा हिस्सा, means whatever the हिस्सा of this hand we have given to the ulnar nerve, because it will supply this intrinsic muscles of the hand. लेकिन हमने क्या किया, means we did something to the median nerve, means we given some favor to this median nerve. This region, which is this thenar or this muscles which is supplying the thumb, it will be supplied by the median nerve. But we know this is dominated, or this hand muscles will be dominated by this ulnar nerve. So हमने क्या किया, we given one muscle supply, just one muscle supply to this thenar muscle. Okay, so the one thenar muscle which is having this ulnar nerve supply. कौन सा है वो? So it is what? It is the Fromm's test. It is the Fromm test. But कौन सा muscle है? Is it adductor pollicis or the abductor pollicis? It is what? It is the adductor pollicis. It is the adductor pollicis. It is the adductor pollicis. So if you want to check this function of this adductor pollicis, you will give a card or this book test. We will call them as Pharma's test. Okay. So when you tell them to hold this book in this position, the patient usually hold like this. But if there is damage to this nerve, then the patient will held by flexion. So because of the flexion, if they held, it is due to the damage of this ulnar nerve, the adductor is not working properly. Okay, you just remember. Okay, I hope this test of this ulnar nerve will help you out. And remember one more thing, this ulnar nerve ऊपर से जाता है. Ulnar nerve will goes superficial to this retinaculum, superficial to the flexor retinaculum. Okay, so you know this mnemonic. Ulnar nerve ऊपर से, ulnar ऊपर. So ulnar nerve, it will go superficial to this flexor retinaculum, whereas this median nerve, it will pass through this flexor retinaculum. ठीक है, इतना याद रखना. फिर उसके बाद आगे बढ़ते हैं median nerve की तरफ. As I told you, this median nerve, it is what? It is one of the nerve which supplies this major muscles of the forearm. So median nerve, it is also known as labrous nerve. To labrous nerve, because labrs, they will hold these things, right? So to holding these things, you need the flexion action. So this median nerve, it is also known as labrous nerve. Like in a case of like if there is any proper adductor function, then the hand will look like this. Fine, it will be this normal side. Okay, because there are other muscles or other branches of the ulnar nerve which will be helpful for this adduction and abduction of this palm, whereas this only one muscle, because rest are supplied by the median nerve. So you want to check only one muscle whether this is working, this ulnar nerve is working or not. You can check with this one test, which is what was this Fromm's test. Okay, because it will supply which muscle? It will supply the adductor muscle. So if the adductor is working, then ulnar nerve is well and good. If it is not working, if it is compensated by this flexion, then it is what? Then it is not working, it is being damaged. Okay, I hope it will address your query. Next, फिर उसके बाद आते हैं कि median nerve. So median nerve, it will helpful for this flexion of your hands and along with this forearms and the wrist. Okay, and this damage to this median nerve will lead to this type of hand, like this type of hand. Okay, this type of hand, which is known as which hand? Benedict's hand. And remember, this type of hand, which is known as Benedict hand, it will happen when you make flexion. When you make flexion, it is known as what? It is known as Benedict's hand. Next one, if you are able to see this type of index finger, this is known as pointing index. This is known as what? This is known as pointing index. So because this flexion will be done by this median nerve. So if there is any damage to this median nerve, okay, this lead to this type of feature, which is known as pointing index. And next, as we saw, this adductor will use for ulnar, whereas this abductor, to test this thenar abductor polycis, will use this test, which is known as pen test. And pen test will use for this abductors. Next, there is, as I told you, right, in supracondylar fracture of this humerus, the nerve which is involved, it is what? It is the median nerve and a branch of median nerve, which is known as anterior introsious nerve. In some situations, this anterior introsious nerve may get damaged. So in such situations, what you will do? You will do a test. You will tell the patient to make OK, so that you can see the patient is OK or not. So you will tell the patient to make this OK sign. Okay, you will tell the patient to make this OK sign to see whether the patient is OK or not. Okay, so if the patient is making like this, then his anterior introsious nerve is well and good. If he is making this weak OK sign, then his anterior introsious nerve is damaged. A good Dr. Amal and good Dr. 𝗏𝗏𝗀𝗏𝗏. Fine. And next one, if you are able to see, this is our classical wrist drop. We know this radial nerve, it will supply these extensors of this wrist. So if there is no extensors, then there will be this wrist drop. Okay, there will be this wrist drop along with this finger drop. So remember, radial nerve injury, it lead to this wrist drop. And about this sensory supplies, we know this is the palmar aspect, and we know the medial side of this palmar aspect, it will be supplied by this ulnar nerve. Okay, and lateral side it will be supplied by the median nerve. Whereas on the posterior aspect, if you see here also, it will be supplied by this ulnar nerve, whereas this around this fingertips it will be supplied by the median nerve, and this posterior aspect of this 2.5 fingers, it will be supplied by this radial nerve. It will be supplied by this radial nerve. I hope we are in pace. We are going very good, very well. I guess I'm not going very much fast. I guess I'm in a ample of pace, so that you can follow it up. So this is kind of revision session, so that you already compiled your knowledge. You need something or some source to come out or to push up, or you can make this as a revision source, like 1.5 hours full anatomy is done, or what you need for the examination, because you are reading everything else, like everything of anatomy, but you don't know what is needed for anatomy. Then what is the mean of reading? So if you see this session of this all 19 subjects, you know what is being asked in the examination, and if you read or revise this session itself, then you will pass the examination for sure. That is my guarantee. Okay. Then if you see about this tendons of the forearm, they will mark you, means they will show this flexed hand, and they will ask you which of the following tendon is this. So sometimes it will be very or bit confusing for you. There will be this tendons you need to know. So you know this ulnar means what are the muscles are this on the medial aspect, it will be the ulnar. So see this one which is around this medial aspect, it is what? It is the flexor carpi ulnaris. So the tendon which is on this medial most aspect, it is what? It is this flexor carpi ulnaris. फिर उसके बाद this, since there is the superficial tendon, this is the superficial tendon, okay, fine. So it is what? It is this flexor digitorum superficialis. We have two flexor tendons, flexor digitorum superficialis and flexor deep tendons, and this flexor digitorum superficialis will be seen superficially because it is superficial. फिर उसके बाद आगे बढ़ते हैं. As I told you, then about this part which is this, which is causing the flexion around this radial joint. So it is what? It is this flexor carpi radialis tendon. So it is the tendon of this flexor carpi radialis. So remember this 3-1, flexor carpi ulnaris and flexor carpi radialis. Right? And next about this anatomical stump box. You can, means there are two things you can do. You cannot forget your passport or your documents and you cannot enter the examinations, or else if you don't study the anatomical stuff box, or if you don't know, like it is not to enter the examinations, or like it is not a demotivating way. I will tell you, like this is that much important. I don't know why they are snuffing from the snuff box. They will ask this examination, these questions in most of these examinations or every alternate examination. So make sure you are doing this topic of anatomical snuff box for sure. Right? The first one, there are two borders. One is this medial one and another one, it is the lateral one. See, if someone is medial to you, so there are two guys who are standing. there are three guys or three fellows who are standing. If you see who is the strongest, if car come and hits, okay, if this is, imagine this is a car, if car come and hits, it will come and hit the lateral person, okay, if flight come and crashes, okay, it will come and hit the lateral person. So the medial person, it is always safe, so he will be always safe. So remember about this medial border, it will be having just one tendon, it will be having this one tendon, whereas this lateral will be having this two tendons, okay. So two tendons of extensor pollicis brevis and abductor pollicis longus, okay, extensor pollicis brevis and abductor pollicis brevis. In both of them, it will be having this extensor component. So remember, this is medial. So medial one is, as he is being protected. If you are having a single sister and two brothers, you will be always protected, and you want to make her to live long. So remember, this extensor pollicis, it is the longest tendon. It is the longest because it is single, so you want to make them to live longer because of your protection. And you know, with protection you will live longer. So remember, this medial aspect, it will be having this extensor pollicis longus, whereas this lateral aspect will be having this extensor pollicis brevis one, brevis, and this abductor pollicis longus, okay. If you know, well and good. Fine. Then they will ask you about this content. The content, it is what? It is the radial artery. And sometimes they will ask you, there is a patient who is presenting to you with following a push injury, or there is a injury which is happening in RTA. Then now patient is complaining of pain over this anatomical snuff box. Which of the following bone will be fractured? It is what? It is the scaphoid bone fracture. Scaphoid bone fracture. It is the scaphoid bone fracture. Remember. And next, if you see this next topic, it is also one of the most important one. Here you need to remember two things. One is what? Is superior gluteal nerve. Superior, remember, superior gluteal nerve, it will supply gluteus medius and minimus. It will supply two muscles, which is this gluteus medius and gluteus minimus, okay. It will supply gluteus medius and gluteus minimus, and both of them, they are what? They are the abductors of hip, okay. Both of them, they are the abductors of hip. So superior gluteal nerve, it will supply gluteus medius and gluteus minimus, and they are the abductors. And you remember this one slogan, okay, one slogan: normal side think, normal side think, normal side thinks, okay, normal side thinks, okay, that's it, okay. It is, if you know this two one, they will ask you the right side. If you see this is the normal one. If you see, the patient is sitting like me, so the patient's right is this, left is this. If you see the left side, the pelvis is dropping, okay. If the patient's left side pelvis is dropping, okay. So the normal one, it is the left side. So the damaged one, it is what? It is the right superior gluteal nerve damage, okay. It is the right superior gluteal nerve. This that easy, because student, they will means like they will make unnecessary confusion in it, okay. Remember, superior gluteal nerve supplies gluteus medius and minimus. They are the abductors and normal side sink, okay. Here the normal side is the left, so left side is sinking, so right side is affected, so right superior gluteal nerve is affected. So that's it, okay, that's it, okay. Then about, sometimes they will give you this image and they will ask you, if you see, this is the gluteus maximus and this is the gluteus medius, and the small one, it is the gluteus minimus, okay, just remember. And if there is any damage to this superior gluteal nerve, it will lead to this type of gait, which is known as Sunderland-Berg. The next image, okay, and this image is being very less commonly tested in FMGE section, but it is very more prevalent in 𝗵𝗵𝗀 perspective. But 𝗵𝗵𝗀 and FMGE, they are the brotherhood. So they can ask the same in your FMGE examination as well. Usually the hip will be having this abductors. So when you stand, the opposite side will tilt, or means when you stand, means the side will try to drop. So it will be maintained by this opposite side abductors. This opposite side abductors, they will pull and they will make them into straight, okay. But if this, imagine this is the same patient which is being standing here, this when he's keeping the steps, okay, when he's tipping the steps, this left side is dropping. Now what need to be done? Then his right side abductor should work, and this hip should not tilt, it should be in normal position, okay, it should be in normal position. Whereas here the abductors is not working, so this tilted hip, it is remaining as tilted, okay, it is remained as tilted. whereas in normal situation it should come like this, whereas here it is tilted. So the normal side it is being dropped. Okay, this is the thing. Okay, so I guess this is the concept behind this Trendelenburg gate. I hope this thing solve your query. Like if you have more queries, just make sure you are asking in at the end of the session or between our breaks. Fine. We'll see about this phenomena. This first phenomena it is what it is, the olfactory nerve passage. It is this. So first one it is this olfactory nerve passage. Then if you see, this is what? This is the optic canal. It is the optic canal which will give passage to this optic nerve. This is this optic nerve. And next, this is the most important. Why it is most important? Because most of our extraocular muscles, nerve sensations will be carried through this. So it is what it is, this superior orbital fissure. This is superior orbital fissure. You know, this extraocular muscles, it will be supplied by this tree. Okay, it will be supplied by this third cranial nerve, then fourth cranial nerve, and the sixth cranial nerve. Okay, fine. It is 3, 4, and 6. And this nerve sensations, this ophthalmic branch of this trigeminal nerve. Okay, V1 will be passing through this superior orbital fissure. Okay, and next about this 3 phenomena which is in an arc fissure. Okay, like an arc, you know, like this arc. Okay, like this arc, like remember it is ROS, rose. Okay, rose to yaad hoga na, yeah, rose. So it is what it is, this foramen rotundum, oval, and spinosum. Okay, and if you see, first we saw this first branch of this trigeminal nerve, it is being passed through this superior orbital fissure. Rotundum, it will give rise to this second part of the trigeminal nerve, which is this V2, and oval will give rise to this or give passes to this third part of the trigeminal nerve. Okay, which is this mandibular branch. Next about the spinosum. The spinosum, it is very important. Okay, they will give you this image of an extradural hemorrhage or an epidural hemorrhage, and they will ask you which of this following artery is responsible for this. Then your answer should be medial meningeal artery. Now they will ask you in which of the following foraminal trauma this artery may get ruptured. So remember, this foramen of spinosum, it will give rise to this middle meningeal artery. So if there is any damage to this foramen of spinosum, then there will be damage to this middle meningeal artery, and there will be damage and causing this epidural hemorrhage. Okay. Next about this structure which is known as foramen of Lesser. Okay. This spine of some is marked here. Okay, and spinosum. This is the spinosum, which have this middle meningeal artery. Okay, and next if you see, this is this internal acoustic canal, and we know this internal acoustic canal which will give rise to this or give passage to this 7th and 8th cranial nerve. And next one, which is this jugular foramen, and here you will be able to see a canal which is known as what? Hypoglossal canal. And this is our main foramen, which is what? Which is this? What is the name of this foramen, guys? The big foramen? Yeah, guys, it is what it is, the foramen of, it is the magnum, the biggest one. So these are this foramina. We know this jugular foramen, it will give passage to this glossopharyngeal nerve, 9th and 10th, and some part of accessory. And we know there are 2 parts of accessory nerve, one is this cranial and this spinal part. The spinal part will be passing through this foramen of magnum. Okay, spinal accessory nerve, Yeah, good, Dr. Anirudh. Next, this axial CT sections, they are being asked in recent years. If you see, mostly they will roam around few asked topics. So if you see this one, this is a T2 weighted MRI. It is a T2 weighted MRI because you will be able to see this water is white on MRI, right? And here you will be able to see these are this ventricles. These are the ventricles. Okay, this is the lateral ventricle, especially this is the lateral ventricles. Okay, and next, this is this lateral ventricles, frontal horn of the lateral ventricles. Fine. And next, if you see around the lateral ventricles, you will be able to see this nucleus. Okay, this nucleus. It is what it is, the caudate nucleus. Okay. And in medicine, they will ask you questions. The patient is presenting with this coriform movement. Which of the following nucleus will be damaged? So if there is any damage to this caudate nucleus, it will lead to the formation of chorea. And next, if you are able to see this structure, which is lens shaped. This lens shaped one. Okay, lens shaped one. This is what it is, the lentiform nucleus. Okay, and we know this lentiform nucleus will be having these 2 components, which is this globus pallidus and the next. If you are able to see this one. Means if you do this block one, right? I guess you will be able to see this one, like this black one. This black one, right? This is what this is, this internal capsule. So this is the internal capsule. There are this internal capsule. There will be two limbs, this anterior limb and a posterior limb. So this is the anterior limb of internal capsule and this is the posterior limb of this internal capsule. Fine. And about this, around this third ventricle, you will be able to see one more nucleus, which is known as what? It is the thalamus. So remember T for thalamus. Thalamus at the level of third ventricle. At the level of third ventricle. Okay. Yeah, good, Dr. Ansh, Sartaj. Yeah, well played. Fine. Next about this ventricles. So remember, we know the CSF will be formed from this lateral ventricle. So with the help of this lateral ventricles, then it will come down. How it will come down? By this foramen of Monroe. Okay. Or this, then followed by this, it will come to this third ventricle. Yeah, it will be produced from this overhead plexus of this lateral ventricle. Then followed by this cerebral aqueduct, and followed by it will pass to this ventricle, which is this fourth ventricle. Once it gets into the fourth ventricle, then it will give passage or it will pass into this subarachnoid space. There are two foramens. Okay, what are the two foramens, guys? The medial one and the lateral one. Medial one and the lateral one. So the lateral one, it is known as foramen of 𝗏𝗏, lateral for 𝗏𝗏, and the medial one, it is known as foramen of Magendie. Okay, it is known as foramen of Magendie. It is known as foramen of Magendie. Okay, and it will pass into this subarachnoid space or the spinal space. Okay, and these are the things you need to remember. And if there is any damage to any part, it will lead to this formation of hydrocephalus. Fine. And next about the stomach blood supply. Mostly they will ask you about celiac plexus. Okay, the celiac plexus, remember the celiac plexus, they will be divided at the level of T12. And the celiac plexus, it will be having these three artery branches. One is this direct left gastric artery, and next one it is this splenic artery, and one the common hepatic artery. Fine. And remember about, mostly remember about this splenic artery. The splenic artery give two arterial branches. One is this short gastric artery, and this, remember, it is the left. We know the spleen is on which side? The spleen is on the left side. So it will give rise to this left gastroepiploic artery. Okay. Then about this right side, this common hepatic artery. This common hepatic artery will give rise to this proper hepatic and the gastroduodenal artery. Previously, this right gastric artery. So I have given this image because so that you won't confuse in the examination. So previously it was a part of common hepatic artery, but now this proper hepatic artery give rise to the branch of right gastric artery. So remember, this left gastric artery, it is a direct branch of celiac plexus, whereas this right gastric artery, it is a branch of proper hepatic artery. Okay, and this short gastric arteries and this left gastroepiploic artery, these are the branches of this splenic artery, whereas this right gastroepiploic artery, it is a branch of this pancreatoduodenal artery. It is a branch of this pancreaticoduodenal artery. So they will ask you this question, and you should not make mistake in it, because I have repeated this so much times, so don't make mistake. Right? And about this muscles of mastication, as I told you, these muscles of mastications, they are derived from this first pharyngeal arch. Okay, and these muscles include this temporalis muscle, this masseter muscles, and two pterygoid, this lateral pterygoid and the medial pterygoid. This lateral pterygoid and the medial pterygoid. Right? These are the muscles of this mastication, and the nerve supply of this muscles, it is what? You know, this first pharyngeal arch, it will be supplied by which nerve? Yeah, guys? It is the cranial nerve. It is the fifth cranial nerve. Okay. What is the mandibular nerve? Mandibular part of the trigeminal nerve. Next one, it is derived from the first pharyngeal. It is derived from the first pharyngeal. And about the tongue, in tongue, you need to know about this nerve supply. The nerve supply, you just remember the same, like here 5, 9, 10. Here 9 and 10 will remain constant. For general sensation itself and taste sensations, both of them, it will be carried by this 9th and 10th on this posterior aspect and the posterior 1/3 of the tongue. Okay, a good Dr. Mehmood Anas. Right? Whereas this taste sensations. Okay, the taste sensations will be carried by this facial nerve, which is part which is known as 𝗏𝗏 tympani nerve, whereas this general sensation it will be carried by this lingual nerve. Okay, lingual nerve, which is a part of this trigeminal nerve, it will carry this general sensation. So remember, for general sensation it is what? It is the 5, 9, 10, whereas for special sensation it is the 7, 9, 10. It is the 7, 9, 10. Remember, and okay, and so they will mark you this anterior 1/3 of this tongue, and they will ask you which of the following carries the general sensations. So this anterior part, yeah, if there is general sensation, it will be carried by this 5th cranial nerve, whereas the special sensations it will be carried by this 𝗏𝗏 tympani, right? Then this glossopharyngeal nerve, it will supply this posterior 1/3 for this both taste sensation and the general sensation. Then about this posterior most, it will be supplied by this both 10th cranial nerve, fine. And about this muscles, you need to, if you can, just remember about this intrinsic muscles, which include this 4 pairs. This is superior longitudinal, inferior longitudinal, transverse muscles, and the vertical muscles. If you unable to remember, just remember about this extrinsic muscles. And this extrinsic muscles itself, you need to remember about this fan-shaped muscle. It is what it is, the genioglossus. This genioglossus, it is what it is, this fan-shaped muscle. It will be supplied by this 12th cranial nerve. Okay, remember. Okay, and there is 2 more muscles, this styloglossus and palatoglossus and hyoglossus. Okay, and next about this esophageal constriction levels. This will be asked in both anatomy and as well the surgical perspective. They will ask you the question. Now, you are planning to do an endoscopy to your patients. Now, you started doing endoscopy. Now, you are feeling a constriction, or this endoscopy is facing some kind of resistance while passing it. And this resistance happens at a level of 25 centimeter from the incisor tooth. So, this will be mentioned at this one. And they will ask you which of the following constriction or which of the following structure will be responsible for this difficulty in passage, or which are this difficulty. Okay, they will ask you this question. So if you see, if there is resistance at the level of 25, it is mainly because of this arch of aorta. So this esophagus will be having this different constriction. The first constriction is at the level of 15 centimeter from this incisor tooth. It is because of this brachopharynx. Means around the level of 25 centimeter, there will be 2 ones. Like first one, it is the arch of aorta, which is on the left side, and remember, as arch of aorta is also on the left side, remember there is this left principal bronchus. It is the left main bronchus or this left principal bronchus which is causing this constriction around the level of 25, but sometimes we refer it as 28 centimeter. Okay, and finally the third constriction, when it enters the diaphragm, it is at the level of 40 centimeter. It is at the level of 14 centimeter, 40 centimeter. In few examinations, from anatomy perspective, they will give this image, and which of the following will cause this constriction. Okay, we know this arch of aorta, first one at 25 centimeter, and this left main bronchus at the level of 28 centimeter, and there is one more indentation. We know the posterior most chamber of the heart. It is which chamber? You see, the left atrium, it is the posterior most chamber. So if there is any changes into this left atrium or left atrial hypertrophy, it will cause indentation to the esophagus. So this indentation, which is pathological, it is due to the left atrial hypertrophy. Okay, fine. And next about this opening of the diaphragm. Okay, about this openings of the diaphragm, there is this central tendon opening, which is at the level of T8. So which opening is this, guys? That is what it is, the vena cava opening. Vena cava opening. At level of T10, it is what it is, the esophagus opening. And at the level of T12, it is the aorta opening. Aorta opening. Yeah, you can remember this by a mnemonic which is known as voice of America. Okay, voice of America. Right? And this is the, if there is an opening at the level of central tendon of the diaphragm, it is what it is, the vena cava, and followed by which you will having this muscular opening which is by or for this esophagus, and finally this aorta which is adjacent to the opening around vertebra, so it is the opening of this aorta. Okay, then we will see about what are the structures which are passing. We know obviously if there is vena cava opening, vena cava will pass, but they will ask you what are the other structure which will be passing through this vena cava opening. So you can remember by this mnemonic of RIP. Okay, it is what it is, the right phrenic nerve and this inferior vena cava. Right phrenic nerve and this inferior vena cava. It will be passed through this vena cava opening. Whereas this esophageal opening, in the esophageal opening, remember esophagus and vagus. So esophagus and vagus ये दोनों T10 पे pass होता है. Remember this esophageal opening at the level of T10 and it will give passage to this esophagus and vagus. Yeah, good, Dr. Pratap, Anuj, yeah, correct, right? And about this aortic opening, remember aorta, aorta, okay, aorta, aorta, okay. So aorta will pass through this, will give rise or passage through this three structures, which is this aorta and then this thoracic duct and this azygous vein, okay. So aorta, thoracic duct and the azygous vein, fine. Yeah, good, Dr. Rohit, good, Dr. Kilche, okay, fine. With this understanding, we'll move on to this TS of this thorax and the abdomen. Like mostly they will ask about this cadaveric images, so make sure you are seeing this image before going to your examination part. So most of our subjects, it will be consisting of only 20 to 21 pages, okay, and if you read this 21 pages before your examination, it is the high yield point and it is the high yield revision that you can have for your FMGE examination, right? As I told you, the most anterior most chamber, it is what? It is the right ventricle. Whereas this most posterior most chamber, it is the left atrium. So the most posterior most, it is the left atrium, whereas the anterior most, it is the right ventricle, right? It is the right ventricle. So they will ask you these two questions. If there is any changes in the left atrium, which is the posterior most chamber, it will cause changes over the esophagus. Whereas if there is any right ventricular hypertrophy or if there is any bullet injury on the anterior aspect, the first thing which will be damaging it is the right ventricle, okay. Then if you are able to see these structures, the structure which is being adjacent to this vertebra, it is what? It is this aorta. Is it ascending aorta or descending aorta? So say guys, this ascending aorta, it is ascending from the heart, so it will ascend very less and it will form the arch and it will descend down adjacent to the vertebra. So the artery which is adjacent to the vertebra, it is what? It is the descending aorta. It is the descending aorta. So remember, the aorta which is adjacent to the vertebra, it is what? It is the descending aorta, okay, fine. Whereas ascending aorta, it is a very small part, okay. Now there is the random question: at which level or at which level from the incisor this aortic arch happens, okay. Then see, these are this pulmonary arteries, two pulmonary arteries, okay. These are the two pulmonary arteries, okay. And about this thorax and abdomen one, this is the thorax one, and about this abdomen one, if you see, this is the air-filled stomach and this is our gallbladder and this is our liver, fine, and this is our duodenum part. And next, if you see this muscular structure, it is what? It is the inferior vena cava. And as I told you, the structure which is adjacent to the vertebra, it is what? It is the aorta. It is the aorta, okay. And this one, which is on the left side, it is what? It is the splenic tissue, okay. Good guys. So just see this image before going to your examination part. And this is, sometimes they give you this CT image and they will ask you A, B, C, D, like that, okay. So see, this is this liver part and below this liver, this is the gallbladder and this is the vertebra, and as I told you, adjacent to the vertebra, it is what? It is the aorta. Next, this is the pancreas part, and next, these are the two kidneys, and on left side you will be able to see this small structure which is this spleen, okay. And this is the pancreas part as I told you, and the air-filled structure which is what? Which is this stomach, right. Then about this femoral triangle, you need to know about this arrangement. This arrangement is naval arrangement. There will be this lymph node around here, okay. There will be one lymph node around here, okay. So this is this nerve, artery and vein arrangement. And just see this medial border, it is formed by this adductor longus, and the lateral border, it will be found by this sartorius. So medial border, it will be found by this adductor longus, and the lateral border, it will be by this sartorius. And remember one more thing, both of the sartorius and adductor longus, both of their medial border will form their medial and lateral border. So let me clarify you. So the medial border of the femoral triangle will be formed by the medial border of adductor longus, whereas this is the lateral border, okay, lateral border, okay, whereas this will be formed by this medial border of. So there is a point of confusion. See, there is a muscle, okay. If you see, this is the medial, this is one muscle, it will be having the two structures. This is the medial part of a muscle, this is the lateral part of the muscle. So see, here the medial part of the muscle, it will be forming the lateral border, okay. This medial part will be forming the lateral border. Just have this in mind, okay. And we'll move on to this larynx anatomy part. You know, this leaf-shaped cartilage, it is what? It is the epiglottis. And we know all of the following cartilages, they can undergo calcification, but except epiglottis, okay, except epiglottis, it won't undergo calcification. There are these unpaired cartilages like this thyroid and cricoid cartilages and this epiglottis. There is rest small cartilages and arytenoid, corniculate, cuneiforms. All of them they are paired cartilages. Fine. And one more question I want to ask you. This is this thyrohyoid membrane. Between this thyroid cartilage and this hyoid bone, there is this membrane which is known as thyrohyoid membrane. And one nerve which go passing through this membrane, which is what? Which is this internal branch of laryngeal nerve. So internal branch of laryngeal nerve will be passing through this thyrohyoid membrane. And one more condition which occurs in this trump blowers. In the case of trump blowers, you will be able to see swelling over here. And the swelling, it is what? It is the which condition, guys? It is the laryngocele. It is the laryngocele, and this laryngocele even it will pass through this thyrohyoid membrane. Okay, and this laryngocele will mostly occurs in a trumpet blowers or who are putting pressure on their mouth. Okay, so this will be what? This is the laryngocele. Yeah, good Dr. Prototype, good Dr. Rohit, and good Dr. Anju. Okay, and we know there is a sign which is known as laryngocele which produces this. It is known as brachial. Okay, you know it is air-filled structure. So once you press it, this air will come out. It is so it is known as brachial. Then about a few important points. Okay, few important points about this vocal cords. If you see, there are many adductors. So many adductors. Okay, but only one abductor. So the adductors include lateral cricothyroid, interarytenoid, thyroarytenoid. Okay, whereas this only one abductor. It is what? It is the posterior cricoarytenoid. Posterior cricoarytenoid. Okay, posterior cricoarytenoid. Just remember this only one abductor. It is what? It is the posterior cricoarytenoid. Okay, posterior cricoarytenoid. Just remember. Next about the tensors. Now in NEET PG examination they asked you. There is a patient who is presenting with loss of pitch. Okay, there is a loss of pitch. And on evaluation you will be able to see bowing of this vocal cord. Bowing of the vocal cord. Okay. So if you are able to see, there is this bowing of this vocal cord. This too will be because of the damage to this muscle, which is what? Which is this cricothyroid muscle. It will be what? Which is this cricothyroid muscle. Just remember one thing, they will give this. There is a patient who is presented with features of loss of pitch, and on evaluation you will be able to see there is a bowing of this vocal cord, and in which of the muscles will be damaged in this condition. It is what? Is the cricothyroid muscle. Right? And about this type of cartilages, they will give this image and they will ask you. If you see this fibrocartilages, they are what? They are very regular. Means they are arranged in a single line because they have this lot of restrictions. They have this lot of restrictions because of this fiber. So it is what? It is this fibers present, then it is fibers cartilage. But you see, there is this fibers, but they are elastic. Okay, they are elastic fibers. Okay, if you see this kind of elastic fibers, it is what? It is the elastic cartilage. Whereas there is no fibers, it is clear. There is no fibers. Okay, they will trust you with the clear heart. So it is what? It is this hyaline cartilage. Hyaline cartilage. Okay. See, most of them, this fibrocartilage, they are single. So single. Here also they are single. Whereas if you see this hyaline cartilage, it is mingled or it is in pairs because they have this trust. They have this transparency. There is no elasticity. There is no fibers. So this is transparent. That is what this is hyaline cartilage. That's why they are paired. They are transparent in their heart. Just remember. Next about we saw this cleft lip. If there is any unilateral cleft lip, it is due to the non-fusion of this medial. Remember, it is the medial nasal process and this maxillary process. Because of this non-fusion of this medial nasal process and this adjacent maxillary process. Right? So if you see this palpation of these arteries, if you see around this medial, about this medial malleolus, it is what? It is this posterior tibial artery palpation, and around this base of this first one, around this base of this first metatarsal, it is what? It is this dorsalis pedis artery, and behind this knee, it is what? It is this popliteal artery. Behind this one, it is the popliteal artery. So these are the few arteries you should remember. So other arteries you know, right? This is what? This is the radial artery. If they are palpating here, it is the radial artery, and if they are palpating near this thyroid cartilage, if they are palpating near, it is what? It is the carotid, and if they are keeping hand near to the femoral region, they are palpating, it is the femoral artery palpation. Fine. And this about this one, which syndrome, which is this hemisection of this spinal cord, and the hemisection of the spinal cord, it is also known as Brown-Séquard syndrome. Brown-Séquard syndrome. And in Brown-Séquard syndrome, you remember only one thing. Okay, only one thing. Okay, there is this ipsilateral pain and temperature. there is the loss of ipsilateral pain and temperature. Okay, don't remember multiple things and forget the necessary thing. Okay, make sure you are remembering the important things. So in the case of Brown-Sequard syndrome, remember there is this ipsilateral pain and temperature deficits, whereas on the opposite side there will be what? There will be the motor movements and the vibration. Okay, everything. Okay, remember this contralateral one. So this pain and temperature, it will be on the contralateral sides. Okay, sorry from my end. So pain and temperature, it will be on the contralateral. So remember this pain and temperature contralateral, pain and temperature contralateral, pain and temperature contralateral seen in a case of Brown-Sequard syndrome. Okay, okay, it is mostly it is below the level. Mostly they won't ask you about at the level. Mostly they will ask you about the below the level. Okay, so pain and temperature loss at the contralateral. If it is on the right side, it will be on the left side. Right? Then there will be motor and vibrations. It will be on the same side, right? You see here this side there is this transaction, and on same side you will able to see there is this fine touch and vibration, and along with this motor functions which is being damaged, whereas on the opposite side you will able to see there is a damage and which will lead to this pain and temperature sensations, because we know there is thing which is known as decussation. Okay, बस इतना याद रखो Brown-Sequard syndrome के लिए, और वो पूछेंगे. Okay, and you should be ready to answer it. And about this auscultatory points, just remember by this alphabetic order. AP, first one. If you see on this right side, like whatever we want, we start on the right side, right? So on the second intercostal space on the right side, you will able to see or hear the auscultation for this aortic valve, right? Whereas on the left side, it is for the P. So remember A, P, okay, A, P, okay. So P for the pulmonary on the second intercostal space, right? Whereas for this tricuspid valve, it is the fourth intercostal space around the parasternal, which is what it's adjacent to the sternum. It is the parasternal line, and around this midline, around this mid clavicular line, and this here you will be able to see this mitral valve. Okay, around this mid clavicular line, you will be able to see this mitral valve, and between this second and this fourth, there is this third intercostal space, which is known as what? Which is known as Earth's point, where you can hear this S1 and S2 simultaneously. Okay, all physicians remember it will go here, it will go alphabetically, it is A and P, followed by this tricuspid valve and followed by this mitral valve. So remember this sequence, and they will ask you which of, they will mark and they will ask you which of the valve will be heard at this position. Okay, so all of this thing about this anatomy part, right? Thank you guys.